technologies. Think things like wearable devices, smartphones, those sorts of data sources. In general, a lot of the data methodology that we develop is applicable to a wide variety of data sources, and particularly the types of data that we're focused on right now is time series data. So looking at how we can leverage information on a temporal scale to make better predictions about what will happen in the future. So a question may come up, why wearables? One of the amazing things about the time that we live in is that there's this confluence of technologies that have come together from um, edge computing to sensing to miniaturization of sensor and computing technologies that have led to many people having smartwatches on their wrists every day or smart rings on their fingers. And so we have this sort of seamless integration of wearables into everyday life. And that makes it much easier to capture information because people are wearing the devices anyway. But what's really interesting about the biosignals that we can collect from these devices is that they're actually more consistent than measurements that we would get in the clinic. And so this is from a paper that we published a few years ago in Nature Medicine, where we showed that if you are to compare heart rate measurements that are taken in the clinic over several years with the heart rate signals that are measured from somebody's smart device, you can see that overall, we have this difference between the heart rate measured in the clinic versus the heart rate measured over the device. But importantly, what we can see is that there's this circadian variation in heart rate that these point in time clinic measurements can't capture. So because we know that biosignals have circadian components, they change over the course of the day, relying on measurements that are taken in the clinic over time and trying to use that to see if somebody's health status is changing can be really tricky. So having continuous measurements that can be compared on a temporal scale, so knowing that this happens at the wake up time for a person each day, even if that wake up time is at 7 a.m. or 9 a.m., might actually be more informative than having somebody come in the morning to give a sample and then in the afternoon to give a digital sample. And something else that's really interesting when we think about current methods of clinical care is that we really rely on these normative values, meaning that there are some standards that have been developed by measuring a large portion of the population, sometimes it's not that large, to say how people compare to the overall population. And that helps us to determine what's normal, what's abnormal, deciding on treatment thresholds. But one of the challenges, and something that I'll show with actual data later on, is that really nobody is normal. There's lots of intra-individual variation. And just because somebody doesn't fit the normal for the population doesn't necessarily mean that they might be unhealthy or need an intervention, but rather what we want to be doing is looking at what's abnormal for an individual. And wearables give us the ability to do that. But there are some challenges that come with working with data from wearables and with working with wearables in general. But here we're really going to focus on the data. So wearables generate massive amounts of data. And, we can think about having different sampling rates. So if we need to measure a signal at 1 measurement per second or 100 measurements per second or even more, or fewer measurements per second, that really kind of expands or contracts the amount of data that we collect. And then you can imagine that across different sensors. So maybe we have a sensor that's measuring heart rate, as one that's measuring blood oxygen, movement, sleep, and you can imagine how this can kind of balloon out as we add more sensors to our smart devices. So one of the things that we are focused on in my lab is turning this data into actionable insights. And we do that through something that we call digital biomarkers. And this field of digital biomarker development is really growing. So in this talk today, I'll start by defining what I mean by a digital biomarker so that we're all on the same lexicon that we're working with. And then I'll talk about some of the challenges, especially because this is a lot of folks in the audience are engineers. there are a lot of challenges that come with digital biomarker discovery that are on the technical side. We'll also talk a little bit about more larger scale issues like privacy and regulatory concerns when it comes to digital biomarkers. And then finally, I'll show one use case of using digital biomarkers of disease for detecting influenza-like illness or COVID-19. As Dr. Randall's mentioned earlier, we have several different projects in the lab. One of our other major projects is focused on pre and type 2 diabetes. At the coffee break, I would love to talk more about that project because there wasn't time in this talk to get to those details. So please, if you're interested in the diabetes sphere, follow up with me and I would love to talk more about it. So let's talk about what a digital biomarker is. The definition here is when we can establish a relationship to health outcomes that are traditionally used in clinical settings. So we can look at this as an equation where on the left-hand side of the equation, we have these target outcomes. That could be your traditional clinical measurements. It could be survey data like patient-reported outcomes or PROs that are commonly recognized by the FDA. These could be illness events, but this would be something that we are used to seeing in patient records or in clinical trials data. The less traditional data that we're working with are these continuous signals coming from wearable devices. And what we do is we take those continuous signals and we build these mathematical functions that can compress that information into an indicator. So you can think of this as, for example, similar to economic indicators. So we might have something like the GDP that takes into account multiple different streams of information and compresses it into one indicator that gives us an idea of the health of the economy. The idea here is kind of the same. We're taking several different measurements, we're trying to aggregate them in an intelligent way that makes them predictive of somebody's health status. And the goal is not only to predict what's going on with somebody's health currently, but also to forecast into the future what these signals might mean for somebody's health trajectory. So an example of this might be we have a biosignal like continuous heart rate that gets input into this mathematical function that we develop. This could be a machine learning algorithm. This could be a simpler statistical model. And we want to forecast what's going to happen with a patient. So that input data could be, for example, continuous location data from a smartphone GPS. And we can transform that into an indicator of, for example, infection. So if you know that there's a hotspot or an outbreak of COVID-19 or some new infection X, some new pathogen X, and you know that a person has been physically located in that hotspot, if you see a distortion in other physiologic parameters, using GPS might be most informative to actually indicate that this is likely to be that disease X. And so that's the type of information that we're trying to capitalize on. And this field, again, I mentioned, is really growing. And so one of the big initiatives that has, stemmed from my lab, but has really taken on this broader community is the DBDP, or the Digital Biomarker Discovery Project. And if you're interested in this area, I really encourage you to check out dbdp.org. On that site, it's essentially a community platform where there's data, code, algorithms, and particularly, I think, useful these educational resources, ranging from very straightforward blog posts of just how to get your feet wet in this field, all the way down to code notebooks that come with data that walk you through how you might do a digital biomarker development. We've had some workshops where we actually walk through these examples, and some recordings are up on the website. And if you're interested in that, I'd be glad to point you toward those resources if you're not finding them immediately on the website. And one other plug I want to put in here is that if this is related to your work and you're interested in either leveraging existing code and data or contributing your own data, code, and algorithms, the idea here is for the community to build upon existing resources. So if you have something that you want to contribute, please contact our team and we will get your code up on the website and get other people contributing to help improve and expand upon that work. So we've talked about what digital biomarkers are, and now, as any good engineer would do, I want to make sure that we talk a lot about challenges. So the challenges that come with digital biomarker discovery are numerous, but very addressable. It just requires a community to begin to address them. So I'm listing here 5 examples of challenges that we're thinking about. And those are related to device and data validity and accuracy. We get questions sometimes from people who say, when I sit down on my couch and watch TV, my device, my smartwatch says that I'm sleeping. How can you trust the data coming from these devices if, I can see on my wrist that my device is saying the wrong thing? So we'll talk a little bit about that. Um, there's also challenges, like I mentioned, with the digital biomarker discovery on this broader scale of interpretability and fair principles. Many groups have been developing one-off solutions that don't come with data and code and make it very difficult to both reproduce and build upon existing work. So one of the big challenges in this field is to start to leverage work that's being done and build upon it rather than having these sort of bespoke solutions. I mentioned earlier this issue of a data deluge. We'll talk a little bit about methods that we can use to address the amount of data we're collecting, as well as the ways that we can compress the amount of data that we have in an intelligent way, leveraging the structure of the signals. We'll talk a little bit about regulatory oversight and kind of the bigger picture of how these tools can be implemented in the real world. And along with that comes these ethical, legal, and social issues, issues of privacy and security. So, some practical, real world examples that I want to give when it comes to thinking about device and data performance is some examples in the real world. And these are a lot of them quite recent examples of failures of digital biomarkers or algorithms that sit on common consumer devices that don't work as well under certain circumstances. So some that have been sort of well established in even popular literature and popular news has been, for example, the pulse oxygenation, and the goal there is to detect low SpO2. This is particularly critical when people have pulmonary issues. We know during COVID-19, this really came to light. And because this is a light-based measurement tool, uh, skin tone can actually interfere, the melanin content of the skin can interfere with the passage of light through it. And that can lead to missed low oxygenation in people with darker skin tones. Um, as you can imagine, that's a really critical problem. There are similar challenges with the contactless body temperature, and we've seen that being used commonly during COVID-19. There's a range of conditions where that might fail, including under varying skin tones, and also in females, where there are some natural variations in skin temperature due to hormonal cycles, and that can cause missed fevers or flu. There's a variety of other challenges. I think one that was fairly recent and quite interesting actually was this crash detection on this was on Apple Watches where people who were skiing would fall down in the snow. It wasn't sort of a car crash or anything like that, but it would automatically call the emergency responders. And at a certain point in the ski season, this was 2 seasons ago, emergency responders stopped coming out because they were getting so flooded with calls that were automated by this crash detection system when nobody was actually in need of that emergency response. So you can imagine how dangerous that is. And so, one of the things that I really want to underscore here is that it's super important to understand how these algorithms are performing in a variety of circumstances. And particularly when we think about health, understanding what circumstances the devices will be deployed in and how the algorithms that we develop for one circumstance may or may not generalize to other circumstances. And so that requires both an understanding of the algorithm development as well as the hardware itself. So this is a slide that I like to show to give us kind of a picture of how to think about not only the algorithms, but also the hardware. So if we think about that physical motion sensor, that would be the sensor that would underlie this crash detection or fall detection or your step count. What it's doing is it's converting physical motion into an electrical signal, and that electrical signal gets converted into digital signals that then get propagated through data processing pipelines on the device and then often in the cloud as well. And so, really, what's happening here is we've got some motion that pushes together capacitive plates that then creates that electrical signal. So, thinking about where do these signals actually originate? And how do we go from this physical motion pushing together capacitive plates leading to something like a step count or a detection that something is a crash? And what are other circumstances that might mimic a step or a crash? So, for example, falling in the snow when skiing, it was found later on actually mimics a car crash. Um, so what's interesting about this is that we have to be very careful with terminology in talking about raw signals, because raw signals can mean a lot of different things. We could talk about the actual change in capacitance or the change in the voltage across the plates. We could talk about the signal that's post analog to digital conversion. We can talk about process signals. We can talk about compressed signals. And at each stage, the data is getting changed and moving farther away from that primary thing that we intended to measure, which is that physical motion. So, in being able to understand what the algorithms are taking in, what that data that's being used to generate a digital biomarker really is, it's important to know where in this process we live. And one of the challenges is that's not always possible because a lot of the devices that we work with are proprietary, or there are technical challenges that come with actually accessing data at these early points because the ability to transfer those large data volumes kills battery, requires wired signals, those sorts of things. So kind of understanding what you do and don't know about where your signal comes from is really important. Another interesting example of this in using consumer devices, and I really love this paper that was written by Collins et al. About where they actually went into the GitHub repositories of Fitbit and Garmin, and they could see how they were making updates on the algorithms that were underlying a variety of things that affect the data that we get in hand. So, we see some of these are bug fixes or issue resolutions, but some of these are kind of interesting, like the green ones are adding features, adding improvements to features. The yellow are adding algorithm adjustments. So if we look at, for example, the Garmin Vivo Smart 3, which is a device that we've used in multiple studies, we can see that there have been changes to the underlying algorithms over time. This is from 2017 to 2019. So if we were to look at our data and see a distribution shift in time, that could be attributed to algorithm changes rather than changes in the population being measured. And it's really important to think about how to best account for that statistically. And in some cases, it may not be possible to account for. And so a new algorithm may need to be developed on sort of the next iteration. So we've worked with the Digital Medicine Society or the DIME Society in thinking about a lot of these issues to try to understand how it's possible to leverage digital tools in clinical trials, in healthcare, to be able to have good faith that the data coming from them does what it claims to be doing, and being able to evaluate those. And we came up with this framework called V3, which is verification, analytic validation, and clinical validation. And if we think back to the example of the accelerometer, so the under the hood example that I showed from that smartwatch of having physical motion that gets translated to a digital signal, we might think about putting that accelerometer on a shake plate and having that shake plate set to a certain RPM. And that could be a benchtop verification that tells us that the device reports out the RPM that that shake plate is set to. Analytic validation would be putting that device on a person and seeing whether it actually picks up on step counts. And we would compare that to the gold standard of somebody measuring steps being taken by a person. Finally, clinical validation comes in when we actually want to put that device onto a patient population, making sure the device can measure the thing that we intend to measure in that population. So, for example, we might have a population of patients with MS, and it's possible that a step that is measured in MS looks different or requires a different algorithm than a step that would be measured in a person without MS. And so we need to validate that when our device is calling a step, that it's doing it appropriately in the population that's being measured. So you can see here that there is this sort of iterative method to the evaluation, which is if there are changes to hardware or firmware, there are new verification and documentation processes that are needed. If there are changes to software that change algorithms, we need to repeat that the devices are doing what we expect them to be doing. And then if we're trying to use these devices in a different patient population than they were clinically validated for, again, if there are expected to be any differences in that patient population in terms of what this algorithm is measuring, it's important to revalidate that the measurements are as expected. So I want to give an example here, like a concrete example of how this sort of process can be done. And I'll focus in on an analytical validation study that my lab did several years back, which was looking at the performance of optical heart rate sensing under a variety of conditions that are notoriously challenging for measuring optical heart rate. So the way that optical heart rate measurement works is that we have something that's typically photoplethysmography. And the way that it works is it passes light under skin and then has a detector, a photodetector, to detect the amount of light that's reflected back. So if you have a smart device that has maybe a green or a red light on the back that you see when you take off the device, that's the tool that we're talking about here. But there are challenges. There are times when PPG can fail. I've already mentioned this issue of high melanin content leading to absorption of this light being emitted, which attenuates the signal coming back to the detector. There's also challenges with noise or motion artifacts where if you break the path of the light, then the light that's being emitted and coming back to that detector doesn't give you back the signal that's expected. There are also challenges with different measurement locations on the body. In some places, for example, we might have lower perfusion, and thus it's just more challenging to actually capture the changes in blood flow in this vascular bed. And that's what's used to get the heart rate signal, is essentially the increase or decrease in blood volume that goes with the cardiac cycle. And then there are some challenges also with physical motion being of a periodic nature, like a person walking, that can actually be mistaken in some of these algorithms for a periodic signal like heart rate or respiratory rate. So the study that we designed, and this was work that was carried out and designed by my former graduate student, now executive in residence at Duke, Brene Benz, um, who essentially designed the study to look across a variety of skin tones. And this was the first time that really this broad spectrum of skin tones had been analyzed for PPG accuracy. And then across a variety of different activities that could result in those sort of periodic signals being picked up. And we compared those to clinical metrics that are considered to be sort of the reference standard or gold standard in the field. And we tested a variety of devices that were sort of cutting edge at the time of this study, that were consumer devices as well as research grade devices. And we compared them to ECG as that reference standard. And what we found was that there was some difference between device type in the accuracy of heart rate. We gladly did not see differences in the accuracy across skin tones. But interestingly, what we did find was that there was up to a 30% decrease in the accuracy of heart rate during activity for some devices. So you can imagine that if the application area for these devices is a study to measure how people's heart responds to exercise, using certain devices in that study would be a complete failure because the device just doesn't work under those circumstances. So, again, this sort of underscores how important it is to be sure that the device that's being used works appropriately under the circumstances of use. And so this is to say that if you're planning a study using wearable devices, thinking about the existing body of knowledge on verification, analytic validation, and clinical validation is important. And also, if that body of knowledge doesn't exist, then thinking about how to generate it for your use case. And one other thing that I'll mention is that oftentimes this isn't necessarily thought about prior to the launching of a study. So for those people who are working on grant applications, for example, this is a really important part that can be written into a grant as maybe the first aim of a grant, which is to validate that the technologies do what you expect and to have alternative paths if not. So that is one of the five challenges that I've mentioned here. I'll talk about a few others. I actually am going to kind of skim through this issue of the data deluge, just giving you an overview of the ways that we think about this, because I don't want to take too much time away from the later aspects of this talk. But essentially, what we're thinking about with the data deluge is that there's this trade-off between the amount of data that we can collect and how well the device or system performs. And that trade-off can be battery life. The less that we collect, the longer the battery life will last. That can be in data volume. So the less data that we collect, the less storage footprint we need, the less we need to transfer. Again, that relates to battery life. The less we need to store on and off device. And so a question comes up about minimizing data volumes while maximizing the accuracy of the digital biomarker. So the ways that we can think about doing this are to first reduce the amount of signal level or raw data we collect. Again, defining what we mean by raw data, going back to that under the hood diagram. And also developing compression methods that preserve the integrity of the data to enable future digital biomarker development. And then there are ways to intelligently aggregate that data into digital biomarkers. So recognizing that there might be duplications in the information contained in signals and being able to intelligently aggregate that. So this one quick study that I'm showing here is in thinking about reducing the overall amount of data that's collected. If we take an example of an ECG at 1,000 hertz, we can see that if all we care about in this signal is heart rate, so that's the peak to peak intervals, then really we could decrease the signal that's collected significantly. So if we look at a PPG that has a low signaling rate, we could see that we still capture these peaks. So this is kind of akin to like the Nyquist rate when we think about signal processing. And so one of the questions that we wanted to ask was, what is the minimum signal collection frequency that we would need in order to accurately capture heart rate related parameters? And so what we did was what you could consider to be sort of an ablation study, where we cut down the or we call it decimation. We cut down the signaling frequency. And you can see that essentially, if we go from 64 hertz of a PPG down to 21 hertz, we don't see a statistically significant difference in the underlying data when it comes to heart rate variability. If we go beyond that, we start to see differences, and that's where we would say that that signaling frequency is too low for the goal at hand. So there are various ways that one might define what it is to be significantly different or similar, depending on the application area. But this is one example of how you might go about thinking about changing the sampling frequency to decrease it. And why does this matter? Like going from, this ECG at 1,000 hertz to, for example, PPG at 21 hertz. If we look at the storage required and we look at the cost, we can see this really exponential decrease in having these really high signaling frequencies versus the low ones. So you can see, for example, that for one user for 1 year, if we are looking at the 64 hertz sampling rate, we're looking at something like $7 per user per year. That doesn't sound that much, but if we start to think about studies that have 10,000 or 100,000 or a million people in the study, we can think of real world examples of this, like All of Us or UK Biobank. That number starts to really balloon. So if we can cut that into a half or a third, all of a sudden the cost for doing the research goes down significantly. And there are other ways to think about this in terms of how we can take the data that's being stored and further lower its footprint. So another work that Dr. Bent led in my lab was looking at different methods to compress data, and understanding whether there are characteristics of the signals that lead to different compression methods being more appropriate. So what we were looking at was on as an indicator of the integrity of the data. So how much information is preserved in that data? We could look at the percent root mean squared difference or the compression ratio. So what we want is really high compression ratios, meaning that we've compressed the data a lot, smaller footprint, and we want lower percent root mean squared differences. So we want the original data and the compressed data to be as similar as possible. And we explored various transformation methods and various encoding methods that are well established in the fields of information theory, and looked at how those perform on these different biosignals. And what we saw, I actually don't have the slide here that actually shows these various signals, but what you could envision is that ECG is a very cyclical signal. It's very repetitive, and therefore provides an opportunity for capitalizing on the structure of that repetitive signal. On the other hand, skin temperature is a pretty steady signal that just has slow changes, typically in time. So that has another type of repetitive information in it, and those two different types of repetitive information can be encoded differently. And so what we could see is that there were different compression and encoding methods that leveraged the structure of the signal that worked better to preserve the integrity of the original signal and also maximize the compression of that data. And so this is something to think about for the long-term storage of biosignals that could be used for future digital biomarker development. Um, I I want to briefly mention that we did a study assessing the risk of re-identification of wearables. And the reason for this is that we are collecting um, lots of time-stamped values of heart rate, temperature, physical activity. Sometimes this may involve location. And we've had a challenge at Duke in trying to figure out, well, where does this data fit in sort of a risk category? And for us, it became sort of a cost issue where high risk data storage is more expensive than low risk data storage. So understanding what is the right designation for this data was of interest. And one of the questions we wanted to ask is time-stamped wearables data of high risk? We performed a systematic literature review to answer this question. This was done with one of my former students, Dr. Lucy Chiquetu. And I will kind of quickly go through this. And actually, I'm going to refer to this paper in the Lancet Digital Health that really walks through the systematic review. And talking about the take-home message of this, which is that ultimately we included 72 studies in our review. And what we found was that this concern of somebody using data that comes from a wearable device to tag them back to other information that they may not want to be publicly findable is possible. And you don't need a lot of data to be able to do that. So if this is an area of interest, again, I'll recommend just checking out the study to sort of better understand when data is re-identifiable and what might be possible to do about it. The last piece that I want to talk about here is in thinking about regulatory oversight. Given all of these challenges that we've discussed so far, how does it come to informing the public or clinicians or patients or consumers of these devices about both the benefits and also the limitations of the devices? So there is a challenge in thinking about the FDA's role in all of this because devices may or may not be under FDA oversight depending on what claims are made on sort of the device packaging. So we know that there's this wellness space that the FDA says is out of their purview, whereas if a device is intended to be used for medical purposes, it falls under FDA purview. One of the challenges I think that we're starting to see in this space is that the line between health and wellness and medical is really blurred. We talked about this more detail during the COVID-19 pandemic when a lot of common consumer wearable devices released an SpO2 or blood oxygen saturation measurement tool that fell under the wellness category when they were released. So what that could look like is we have a smart watch that has a functionality on it like irregular heart detection, which happened at this time, and this was under the FDA's purview, whereas this other functionality was not FDA regulated. So, how to convey to patients and to clinicians that this functionality of this same device is more trustworthy or more regulated than this functionality is really challenging. And so I think there's a lot of work to be done in the policy space and in thinking about how to not only convey information, but also how to improve the regulatory aspects of such devices to ensure that we maintain a trustworthy environment for them. And we do a lot of work with both the Digital Medicine Society or DIME Society and the FDA as a part of their network of digital health experts to help to guide how we can improve methods of regulatory oversight, like one of the challenges that I just mentioned. Um, so I want to now switch focus to talking about the actual digital biomarkers of disease that we've developed. So taking the data coming from these devices and putting it into practice to be able to detect or predict certain health outcomes. And like I mentioned at the beginning, I'll talk here about the influenza-like illness or ILI and COVID-19. And I'd be glad to talk at the break about pre and type 2 diabetes. So a lot of this work stems from work that I started as a postdoc at Stanford, working with Mike Snyder now almost 7 years ago. And the idea was that we had this study that was going on where there were 100 people, and actually these were people that some had prediabetes and some were healthy, and they were measured over the course of many years. So at the time that I had moved from Stanford to Duke, it had been about 7 years. So you can imagine now they're going on probably roughly 14 years. And this cohort was monitored in daily life. They were wearing smartwatches at all times and then would come to the clinic quarterly. So at these four predetermined times of the year to give samples. So this could be, these were liquid samples, so like blood, urine, there were stool samples, there were microbiome swabs of skin, all sorts of omic samples that the aim was to relate them back to clinical measurements that were also taken at these visits. And so the beauty of this data set was that there were people wearing wearables throughout the course of this that could be related back to these sampling. Also, interestingly about this study design is that when people had any sort of abnormal event, they could come in to give additional samples. So we had instances of people naturally being infected with virus or having stressful life events. There were some people who ended up staying up for 48 hours straight for various reasons, and we were able to kind of see what that sleep deprivation did. There were people who had dietary changes, and so all of that could be witnessed and is still sort of under analysis by the various individuals on Mike Snyder's team. The work that I did was really focused on the wearable devices data. So we can see here that looking at the x-axis here is individuals. So each tick is a different person in the study. There are 43 people represented here. We can see the skin temperature with these blue triangles, the heart rate with these red circles, and then the black squares are saying how much data in time. And so one of the things that's interesting is that even as the data amount decreases, so somebody wears a device for less time, the data is still pretty representative. And so it starts to get to this question of, well, how much data do you actually need to collect on a person in order to be able to make predictions about their health? Also, interestingly, if we look at the skin temperature, we see a really tight range, and that makes sense given what we know about temperature and about how temperature dysregulation can only go so far and somebody's still sort of alive and ticking. Whereas if we have heart rate, we have a much wider dynamic range. And so, in thinking about that further, we can explore people who have similar um, mean heart rates. So, an example would be this person that my mouse is hovering over. I'm not sure if you can see this. Let's see if I'll put on the laser pointer. So, you can see that we have somebody here with a similar mean heart rate as a person here. But if we take heart rates that are within the standard, within the 95% confidence interval of this person's measurements, we could see that a measurement here wouldn't be very concerning for this person. But for this person with the same mean heart rate, that would be very much outside of their norm. So this gets back to this question of individuals are not norm, they're not the average, right? So if we take this population level look at people and we say, well, this person is outside of the population level norm, that might not be a problem for that person. But for somebody else, they might actually be within the population norm, but they're outside of their own personal norm, and that is a problem. And so we can see these examples in various different ways. Another type of digital biomarker that we could look at is circadian variation. There are decreases in heart rate during sleep. So we can see that here the change in the nighttime versus daytime heart rate in general for most people decreases. And there's also a general increase in skin temperature during sleep. But what we can see is that difference varies for different people. And there are even different people who have the opposite of what we might expect to see. So the question then becomes, well, when we see different trends, how much are those intra-individual variations versus how much are those, inter-individual variations versus how much are those indicators that somebody might be unwell? And what we did was we developed this algorithm that we call change of heart, which is essentially an anomaly detection algorithm for longitudinal monitoring. In this study, we were using the Intel Basis Watch. We had measurements of heart rate, temperature, galvanic skin response, which is similar to electrodermal activity, and physical motion. And we had for each of these sensors measured at roughly 64 hertz. So we had, you can imagine, a lot of measurements per day. And for each of those measurements, we binned them into how similar they were to the mean for that day. So you could see that essentially we end up with sort of a radar diagram where measurements that are more like the norm end up in the are not like the average for the day, but are like the average for the entire monitoring period. So essentially we want to know for this day, how similar was this person to the rest of their monitoring period looking backwards into the future. And so we could see that if we have blips on the radar here, that corresponds to somebody having a lot of abnormal measurements, either high heart rate, maybe more than 2 standard deviations above the mean, or lower than 2 standard deviations below the mean. And applying that to a real person's data here, what we can see is that this is monitoring over the course of roughly a year and a half. This is an example where there are blips on the radar that pop up for heart rate, and there were also blips on the radar that pop up for skin temperature. And it turned out that going back to the electronic health record, because recall these were people that were sort of heavily monitored over the course of those few years, we could see that that corresponded to a Lyme disease infection. And that was further validated by looking at the different clinical metrics, including white blood cell counts, and ultimately a positive antibody screen for Lyme disease. And so what this shows is that if we looked at data over a long period of time, we can find these anomalies that may be indicative of disease. Taking the data from this same person who had many in-clinic visits, we can actually plot all of the times that the person came into the clinic and look at the concomitant smartwatch data. So what we're looking at for each of these dots on this plot is the skin temperature and heart rate measurements coming from the wearable device for a clinic visit date that would have a corresponding wet lab sample and clinical measurements being taken. So if we're looking at things that are on the outskirts here, we can see that those are outliers. Those are anomalies on this smartwatch radar diagram. And when we look at these anomalous days, we can see that these most anomalous days for that person correspond to that Lyme disease infection. There are these other outlying days that we wanted to better understand whether they corresponded to anything interesting. And in fact, one of them was noted, the person came into the clinic for a known viral infection. Interestingly, some of these other outlying days had high measurements for C-reactive protein, which is sort of a general metric of overall inflammation. So what's really fascinating about this is that even though the person didn't themselves feel sick or report into the clinic for a reason, they had a high level of underlying inflammation that was actually detectable through the smartwatch data. This raises lots of questions about sort of when is it important to act on data versus not, and what subclinical inflammation might mean. But I think really the beauty of this idea is that there are things that a person might not themselves know is going on in their body that might be an indicator for a longer term problem. And so to be able to understand how to better leverage that data, going from these individual baselines to the development of digital biomarkers leads to the ability for early identification of acute and chronic illness. So we took this idea a step further in thinking about how we could use anomaly detection to improve pandemic-related infrastructure, given that we had already been doing studies of flu, RSV, and rhinovirus prior to COVID-19. It seemed natural to extend those digital biomarkers to the detection of COVID-19. And you can imagine that there are lots of application areas for that. So we can improve some of these analog methods of case investigations, contact tracing, the way epidemiologic surveillance is currently done, even thinking about communication through smart devices and vaccine trials and development, that there's this whole digital infrastructure that really kind of remains to be tapped into. We saw some examples of that with the digital contact tracing by phones being close to each other, but we really didn't leverage the digital infrastructure to the extent that we could have. And the hope is that we continue to develop new technologies that can help to prevent the next pandemic. And so what we focus on in our work right now is leveraging this digital infrastructure for early detection and public health monitoring. There are also cases for at-home monitoring, or for hospital triage or better understanding who's at highest risk, who might need the most resources. And then future work is in delivering this information and understanding how it could be actionable. So we developed this CovIdentify study in March of 2020, and our overarching aims for this study were to learn who should be quarantined or tested and when, and who would need specialized care resources and when. And I think, many folks on the call actually joined the study and donated their smartwatch, filled out daily surveys to help answer a lot of these questions. Our goals, and a lot of this work is still ongoing with our furthering of this work with our BARDA collaboration, is looking at if we can determine who might be more susceptible to infection, aside from who may currently have a COVID-19 infection, looking at pre or asymptomatic infections, understanding how contagious a person might be if they are infected. And a lot of these come down to when we're thinking about resource limited settings. For example, we have a group of people that we know we need to choose a subset to be exposed to an infection, or we need to choose a subset who's least contagious that has the infection. And you can imagine there are a variety of settings where those challenges start to come into play. And so we collected a large amount of data. We had over 7,300 people enroll in the study. Of those, we had 1,289 that reported a COVID-19 test. Many of those we saw were surveillance tests. So one of the challenges that we are still working through is differentiating for COVID negative. Was it a surveillance test and somebody did not feel sick versus is it a negative test, but somebody may have had a different sort of illness? And then we had 132 COVID positives. And we can see here, just looking overall at the smartwatch data, we see this decrease in steps, and we see an increase in resting heart rate in the time leading up to the test. This detection window is pretty wide, and one of the reasons we think this might be is because it was hard to get tests early on in the pandemic. So by the time people got tested, a lot of times it was much later in their infection than it might have been otherwise. So the true positive date might have actually occurred somewhere in here, but there wasn't the ability to get a test at that time. And so, in thinking more about the shortage of diagnostic tests, we thought, well, could we develop an algorithm leveraging smartwatch data that would improve the way that diagnostic tests are allocated, such that we don't have these shortages and that the tests are optimized to catch more positive infections? I want to emphasize that this is a different use case for diagnostic tests than it would be for population level surveillance. So this would not help us to understand what is the baseline rate of infection in a community, but rather would be most effective for people who think that they may be sick, making sure that we allocate those resources to the people who are truly most likely to be sick. So what that looks like is, if we think about allocating tests, we have a population of people. Here, orange is representing somebody who actually has COVID. Blue is representing somebody who does not. And we have fewer tests than we have people who want to be tested or are in line to be tested. If we randomly allocate these tests, or just let any one of these people go ahead and grab a test off the shelf until there are no more tests left, we would result in an 11% positivity rate. But if we are to leverage a priori information like biosignals from a smartwatch, we can increase that positivity rate to 44%. So we can capture more positive cases using the same number of diagnostic tests. So the way that we did that was in trying to separate out, using machine learning, biosignal patterns that are indicative of somebody having COVID-19 versus not. And we performed sort of an extensive grid search using a variety of different temporal parameters. So this was sort of a hyperparameter search that enabled us to hone in on an optimal algorithm to separate out those who are most likely to be positive from those who are most likely to not be positive. And so the most interesting results, really, so these are the overall results, and you can see our train results and our test results. But in looking here at the algorithm that we developed, the intelligent testing algorithm, when we have a very low number of diagnostic tests that are available, which is the case often early on in a pandemic when a new disease emerges, and we're seeing that more and more frequently now, for folks that are paying attention to, the disease X that's just popped up in the Democratic Republic of Congo. Like this is something that is not going away. And so we know that these early days of disease X exist. And to be able to optimize who gets tested so that we know who's positive and we can prevent the spread is super important. And that's really what we're looking at here, is trying to employ this ITA algorithm in cases where we don't have enough tests for the number of people that we would like to be tested. And so the take-home message for ITA is that it results in a 6.5-fold increase in the positivity rate in the cross-validated training set, a 4.5-fold increase in the independent test set, and really importantly is this asymptomatic group here. So we were able to catch people who otherwise didn't feel sick. And in a scenario where you're really trying to catch those true positives to prevent spread, catching the asymptomatics is really important. We leveraged both resting heart rate and steps features. They were important at different times in the trajectory of the infection. You can read the paper if you'd like more detail on that. But ultimately, I want to show an application area of this for public health. So this is sort of the last slide before my summary, which is to show that there is this really clever group that used Fitbit data from across the country to show that they could actually anticipate influenza-like illness outbreaks from Fitbit data better than the CDC flu tracker could. The reason for that is that the CDC data is on a lag. It's typically a 2-week delay from the local public health offices to get that data out at the national level. And so that manual process of data transfer can be sort of overtaken by this in the moment instantaneous analysis of biosignal anomalies on a really large population scale. So this is something that we're super excited about and also thinking about in terms of digital biomarker development. So in thinking about the overall summary of digital biomarker development, digital biomarkers are digitally collected data that are transformed into indicators of health outcomes. There are a lot of engineering challenges that come with digital biomarker discovery, lots of room for contributions and research in this area. And again, just a plug for DBDP at dbdp.org to get involved to address these. And we can see that digital biomarkers can be used as early indicators of illness. In particular, what I've showed today was infection. So there were lots of folks who contributed to the work that I presented today. And if there are any questions, I'm not sure how much time we have now, so I'll leave that to Dr. Randall to let us know, and then we'll be glad to talk more at the break.